Okay, let's unpack this. Imagine a health topic that is, well, incredibly widespread, particularly affecting young adults, yet one that often operates completely in the shadows, sort of hidden from plain sight. We're talking about something hundreds of thousands of people have right now here in the UK, and most of them have absolutely no idea.
Yeah, that's right.
Today, we are doing a deep dive into chlamydia.
That's right. And it holds the, well, unenviable title of the most common sexually transmitted infection here in the UK.
Wow. Most common.
And as you said, its silent nature is probably its most significant characteristic and its biggest challenge, too.
Absolutely. And that's exactly why we're doing this deep dive for you. We've taken a stack of revision notes and, clinical overviews on chlamydia, the kind of high-yield factual stuff you really need to grasp, and we're going to unpack it point by point.
Right.
Our mission is to make these essential facts stick, covering everything from the basic definition right through to the potential long-term consequences.
Think of it like we're navigating these notes together. We'll look at what causes it, how it spreads, who's most at risk, what it actually does inside the body.
What else it might look like.
Yeah, what else might look similar, just how common it is, what symptoms might pop up, or, more likely won't. The best ways to diagnose it, how we treat it, and crucially, what happens if it's just left untreated.
And it's not going to be like a dry recitation. This is a focused conversation, pulling out the really important nuggets from the source material to help you understand the core info quickly, efficiently, especially if you're revising.
Exactly.
So let's just dive right in.
Okay, so pulling straight from the top of the notes, the fundamental definition. What is chlamydia? Well, it's an infection caused by a specific type of bacterium, Chlamydia trachomatis.
Right, so it's a bacterial invader, and it's firmly classified as an STI, a sexually transmitted infection.
Yep.
The notes emphasize it primarily affects the genital tract in both men and women.
But, and this is interesting and maybe sometimes missed if you're just glancing at a summary, the source material makes it really clear it's not exclusively limited to the genitals.
Oh.
Yeah, this bacterium can also cause infections in the rectum and even the throat. That's actually a key anatomical detail to keep in mind for testing and, well, symptoms, or the lack of them.
That geographic spread inside the body is important then. So how does this particular bacterium actually get from one person to another? What's the etiology, the cause of the infection spreading?
Well, as you'd kind of expect for an STI, the source confirms it's transmitted through sexual contact.
Right.
Specifically, vaginal, anal, or oral sex with someone who is already infected. It's a direct transfer of the bacterium.
Pretty straightforward, really.
Yeah.
Which leads us naturally to who is most susceptible? What are the key risk factors the notes highlight?
The notes are quite clear here. Unprotected sexual intercourse, meaning sexual activity without using barrier methods like condoms, that's a major risk.
Makes sense.
And having multiple sexual partners is another significant factor.
And interestingly, a history of having had chlamydia before puts you at higher risk of getting it again.
Wow.
It doesn't give you, lasting immunity.
Absolutely not. And this next one is critical from an epidemiological standpoint and something the source material really emphasizes: age, specifically being under 25.
Ah, yeah.
This demographic is just disproportionately affected. And this links directly to why screening programs often target this specific age group.
It feels like that age factor is almost a risk factor because it's just so prevalent in that group,
Pretty much, yeah.
Lack of consistent condom use is listed too,
Yeah.
which obviously ties into unprotected sex, but it's worth maybe noting separately as a behavioral risk factor.
Yeah, it just reinforces that barrier methods are really key for prevention. Now, once Chlamydia trachomatis gets into the body, what exactly does it do? What's the pathophysiology described in the notes?
It's described as infecting cells, particularly those lining the epithelial surfaces in the genital tract, and this cellular invasion triggers an inflammatory response.
Right, the body reacts to the presence of the bacteria with inflammation. And here's where it gets really interesting and connects back to that silent but serious aspect we mentioned.
Okay.
The notes explicitly state that this inflammation, if it's left untreated, is the pathway to significant complications. It's not just the infection itself causing immediate chaos everywhere, it's the untreated inflammation that sort of cascades into problems.
Like what kind of problems?
Like pelvic inflammatory disease, PID, infertility, and even increasing your susceptibility to HIV. That untreated inflammation step is crucial in the pathogenesis chain.
That's a vital connection. It helps understand the why behind needing treatment, even when there are no symptoms at all.
Exactly.
We're trying to prevent that long-term damage from silent inflammation. Speaking of symptoms, or their absence, what else might someone think they have if symptoms do appear? The differential diagnosis bit.
Yeah, good question. The source material lists several other conditions that can, well, mimic chlamydia symptoms, particularly the genital ones. Gonorrhea, caused by Neisseria gonorrhoeae, is the classic one, often tested for together.
Right, the other common STI.
Then there's trichomoniasis, which is caused by a different kind of bug, a parasite called Trichomonas vaginalis. Genital herpes from the HSV virus is another possibility, especially if you're thinking about painful lesions, though, there can be some symptomatic overlap.
Okay.
And even a simple urinary tract infection, a UTI, can cause painful urination, which is also a potential symptom of chlamydia.
So you can't just assume.
No, the notes stress the importance of considering these other possibilities when evaluating someone, not just jumping to chlamydia based on one non-specific symptom.
It requires a comprehensive approach.
Yeah.
So let's zoom out a bit. We've touched on the age group, but how common is this silent infection overall? Let's look at the epidemiology, specifically the UK data cited in the notes.
What's fascinating here, and something to really cement for revision, is that chlamydia is definitively the most common STI in the UK.
Most common. Wow. That statistic alone is really telling.
It is. And as we mentioned under risk factors, the notes reiterate it disproportionately affects young adults, zeroing in on that 15 to 24-year age range.
And the scale is significant, giving you a sense of the public health challenge. The source states there were over 220,000 diagnosed cases reported in England back in 2019.
Yeah.
That number really highlights the prevalence, especially when you think about how many cases probably go undiagnosed.
Exactly. That scale really underscores why proactive screening in that key demographic isn't just, a good idea, it's essential for control. Which brings us neatly to the clinical picture, what it looks like or doesn't. This is a really high-yield section for anyone studying this.
Okay, the absolute most important point here, repeated throughout the source material. Most individuals with chlamydia are asymptomatic.
Right.
You cannot rely on symptoms to find cases.
Yeah.
This is the central challenge of chlamydia, isn't it?
It really is, but when symptoms are present, they can vary. Across both sexes, potential symptoms include abnormal vaginal or penile discharge and painful urination or dysuria.
Women might experience lower abdominal pain or maybe abnormal bleeding between periods, that's intermenstrual bleeding or bleeding after sex, postcoital bleeding.
Yeah.
Men might notice testicular pain or swelling.
And the notes provide some helpful specific details here, too. For males, chlamydia is a major contributor to non-gonococcal urethritis, NGU. It accounts for 35–50% of cases.
Wow, that's a lot.
Yeah. Symptoms like dysuria or urethral discharge usually appear about 1 to 3 weeks after exposure.
But for females?
For females, the notes emphasize again that up to 80% are asymptomatic.
80?
But if symptoms do show up, they can be those we mentioned. Altered discharge, the bleeding irregularities, maybe painful sex that's more superficial, dyspareunia, and low abdominal pain.
Okay. And what might a doctor see on examination?
On examination, a healthcare provider might see signs of inflammation on the cervix, things like mucopurulent discharge, which is sort of pus-like swelling, or edema, redness, erythema, and the cervix bleeding easily when touched. That's called friability.
Those specific clinical signs are important flags then during an exam, even if the patient doesn't report many symptoms themselves.
Definitely. And tying this back to the complications again, the notes explicitly state that untreated infections in females lead to pelvic inflammatory disease, PID, in about 10–20% of cases.
And PID, as we noted, is that serious complication causing chronic pelvic pain and dramatically increasing the risk of things like ectopic pregnancy and infertility.
Exactly. It's that chain. Silent infection, inflammation, PID, potentially really serious reproductive consequences.
The clinical presentation, or rather the lack of it, is the real weak link in detection, isn't it?
Precisely. So if symptoms are often absent, how do we reliably diagnose it? What investigations are required, according to these notes?
The preferred method, the gold standard cited, is nucleic acid amplification tests, NAATs.
NAATs.
Okay. These are highly sensitive tests that detect the DNA or RNA of the bacteria itself.
And one reason they are preferred is their flexibility in sampling, right?
Yeah, exactly. They can be done on urine samples, which is non-invasive and pretty convenient, or, as the source notes, on swab samples taken directly from potentially infected sites. That depends on exposure history. So swabs from the cervix, urethra, rectum, or even the throat. NAATs are the key diagnostic tool here.
Got it. The notes also add some detail about older methods like light microscopy. I think it mentions that while you might see white blood cells, neutrophils under a microscope, you absolutely cannot identify Chlamydia trachomatis itself with gram staining.
Right, that's an important distinction.
Yeah, microscopy can still be useful for, say, ruling out gonorrhoeae, especially in male urethral swabs, but for chlamydia diagnosis itself, it's got to be METs.
That distinction is important for testing strategy. Okay, so we know what it is, how it acts, how common it is, how to find it. How do we actually get rid of it? What's the management approach outlined in the notes?
Okay, management covers both prescribing and non-prescribing aspects. On the prescribing side, antibiotics are the treatment. Simple as that.
Yeah, which ones?
The commonly prescribed options highlighted are azithromycin and doxycycline. The notes specify doxycycline at 100 milligrams twice a day for 7 days,
7 days.
adding the crucial caveat that it's not for pregnant individuals.
Ah, okay. So what about pregnancy?
Well, azithromycin is noted as safe during pregnancy, making it a key alternative in those cases. The specific dose isn't detailed right here in this part of the notes, but it's the go-to for pregnancy.
And there are second-line options too, right?
Yes, erythromycin, also listed as safe in pregnancy, and ofloxacin, which is explicitly noted as not safe for pregnant individuals. So pregnancy status is really paramount when choosing the antibiotic.
Definitely something to remember.
The notes also recommend something called a test of cure, basically repeating the test after treatment.
When is that needed?
Specifically after using those second-line agents, or for pregnant women, even if treated with first-line options like azithromycin, it's just an extra layer of caution to make sure the infection is definitely gone.
Okay. Beyond the pills, there's essential non-prescribing management. This sounds important for stopping the spread.
Absolutely critical. The notes advise abstinence from sexual activity until treatment is completed, and that means for both the patient and any treated partners.
Both partners need to finish treatment before resuming sex.
Got it.
And the public health backbone of STI management, contact tracing, and partner notification. You have to inform sexual partners so they can get tested and, if necessary, treated. It's about breaking that chain of transmission.
Makes sense.
So overall management involves screening high-risk groups, like young people, and educating everyone about safer sex practices and the importance of getting tested. Prevention and early detection are really key.
So if someone is diagnosed and treated, what's the outlook, the prognosis? The good news, clearly stated in the notes, is that chlamydia is treatable with antibiotics. If it's caught and treated appropriately, the infection is usually cleared completely. The immediate prognosis for resolving the infection itself is excellent.
That's reassuring. However, there's always a however, isn't there?
There often is, and this is the flip side that's emphasized. The prognosis gets complicated by the risk of those complications we've touched upon. Untreated chlamydia can lead to significant, potentially long-term problems.
This brings us right back to that final crucial section in the notes. The complications that can arise if this often silent infection is missed or ignored.
Yeah, we've circled back to this because it's basically the main reason we care so much about finding and treating this infection, even when it's quiet.
So remind us again, what's the primary complication for women?
Pelvic inflammatory disease, or PID.
PID.
PID is an infection affecting the upper reproductive tract, so the uterus, fallopian tubes, ovaries. It can cause chronic pain and, very significantly, scarring that leads to infertility.
Yes. Infertility resulting from that scarring and damage, particularly to the fallopian tubes, is a major potential long-term consequence of untreated chlamydia. Really serious stuff.
It is. The notes also list an increased risk of acquiring HIV if someone is exposed while they have chlamydia. That's another serious comorbidity to consider.
And for pregnant individuals, there are specific risks there too.
Yes. Risks like premature birth, low birth weight for the baby, and the potential for the infection to be passed to the newborn during delivery.
What can happen to the baby?
It can cause eye infections like neonatal conjunctivitis or even pneumonia in the newborn.
Okay. Looking back through all these notes then, what are the absolute highest yield points you think someone needs to really lock down for revision? The must-knows.
Okay. I'd say, number one, definitely the asymptomatic nature. Most people have no symptoms. You absolutely must remember that.
Right. Don't rely on symptoms.
Second, the key risk factors, particularly that age group under 25. Third, knowing that NATs are the diagnostic test of choice. That's non-negotiable for exams.
Yeah.
And finally, really understanding that list of serious potential complications, PID, infertility, and crucially, how they stem from that initially silent infection. Telling yourself that story, from hitting bug to potential long-term damage, that helps make the facts stick.
Yeah, that narrative helps. Those points really explain the whole public health strategy and the urgency of finding cases, even when no one is complaining of anything.
Exactly.
So, what does all this mean then? We've taken a deep dive into the core information about chlamydia, pulling directly from those revision notes and clinical overviews that you might be working with.
Yeah, we've covered everything from the bacterium itself, C. trachomatis, to how it's treated and the significant risks if it's not treated. The structure and the specific details, like the prevalence data and those treatment regimens, should give you a pretty solid foundation.
And it really leaves us with a final provocative thought, perhaps, for you to consider as you synthesize all this information. Given the profound impact of chlamydia's asymptomatic nature on its spread and that risk of silent long-term damage, how does this single characteristic fundamentally challenge traditional approaches to healthcare? The ones that often rely on patients presenting with symptoms.
Yeah, that's a great point. It really highlights the need for a different approach.
It raises a really important question about the role of proactive screening, especially in young adults, in modern public health, doesn't it?
It forces a different way of thinking about finding disease, definitely, not just waiting for people to feel sick.
Well, if you're finding this kind of structured, high-yield deep dive helpful for your studies and revision, you might find more resources like this, structured in a similar way, over at PassTheMSRA.com and FreeMSRA.com.
We certainly hope this deep dive into your source material has been valuable for you today.